Okay, in order to understand why we want to go to a chemo-free world in lymphoid malignancies, you need to understand where chemotherapy came from. It started with dumping mustard gas on the Allied forces in World Wars I and II, resulting in awful toxicities, but in lymphocytopenia. And so nitrogen mustard was injected into lymphoma patients, resulting in transient but impressive responses. And now derivatives of mustard gas are what we use in most of our lymphoma therapies, all the alkylating agents. So it makes sense to try and develop kinder and gentler forms of therapy that are at least as effective. And we have been developing chemo-free treatments for lymphomas since 2004. And we started off with doublets of monoclonal antibodies, and then we developed a regimen called R-squared, rituximab and lenalidomide. And we did a relapse study and then a frontline study as did Dr. Fowler, resulting in the relevance trial. The relevance trial was R-squared versus R-chemo. And the results showed that R-squared was associated with a similar response rate, progression-free survival, and overall survival with less toxicity than R-chemo. So it gives us the opportunity to use a non-chemo regimen for the frontline treatment of follicular lymphoma. The same thing for Waldenstrom's macroglobulinemia, where we have a high level of efficacy with BTK inhibitors, first ibrutinib and now acalabrutinib, positioning them to be the initial treatment for Waldenstrom's. And finally, in chronic lymphocytic leukemia, after years of alkylating and nucleoside analog-based therapies and the fight between FCR and BR and then the different anti-CD20s, we now have rituximab idelalisib, we have ibrutinib, and we have venetoclax. And there are several studies with these drugs, such as the Murano trial, which was rituximab, venetoclax versus BR in relapsed CLL, showing that the biological doublet was far superior to the chemoimmunotherapy. And there are numerous other trials that are ongoing looking at different combinations and permutations of non-chemo agents to try and improve the outcome of our patients. The problem is we don't know which drugs are the best to combine for which patient. And that's the goal of future research, to identify using next generation sequencing or other molecular genetic studies to say which patient can get away with one drug, which patient needs 2 or 3 drugs, and which are the drugs that would be best suited for that individual patient. Because in the next few years, chemo will be gone, and it will be the chemo-free regimens that will be curing the patients with follicular lymphoma, Waldenstrom's, and chronic lymphocytic leukemia.